Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot.
And today, as I am each month, I'm delighted to be joined by Dr. Craig Joseph. But this week we have a special guest joining us, Dr. Jayne. She is the resident blogger at His Talk. She's also an urgent and emergency room care physician, widely experienced among the medical informatics community. Thanks to both of you for joining me today.
Glad to be here.
It's a pleasure, Nick. And yeah, typically it's just you and me. And now I feel like we have royalty with us today. And so even though she doesn't have an accent, Dr. Jayne is royalty to me.
I can't agree with you more. So let's kick off. We're at the beginning of the year. And I always think about what's going to happen. I look back at the previous year. It's sort of arbitrary because it's, the calendar year. Tell us, if you would, Dr. Jayne, your thoughts for what's going to happen in 2022 in the healthcare space.
Yeah, so I think we're going to continue to see a lot of organizations in transition. Certainly the pandemic shows no signs of being over. And I think at least in the US, a lot of us are still waiting to come down the backside of this horrific epidemiological roller coaster that we've been on for the last, month and a half, 2 months. And I think organizations are going to spend any downtime they have trying to figure out how to recover from that and also how to catch up on any of the priorities from 2021 and 2020 that they didn't get done because they were busy dealing with COVID. So most of the organizations that I work with, they have a lot of things that they'd like to do as far as usability and patient engagement, user satisfaction, but those efforts really have gotten derailed during all of this. I think you've seen a lot of organizations that haven't been willing to spend any money because they've been trying to deal with COVID. And hopefully, if we move into a more endemic stage with the pandemic, we'll see more organizations start to loosen those purse strings and maybe make some of those technology investments that they've been putting off for the last 2 years as well. So for those folks that are on the vendor side, I think that's very exciting. They've certainly experienced these ridiculously long sales cycles over the last couple of years because nobody wants to do anything because we don't know what's going to happen tomorrow or next month or in 6 months. And I hope we see a lot of relaxation with that. That's my optimistic prediction. Of course, I have some other predictions that, I don't want to be Debbie Downer today. So I'll just leave it that with the optimism.
I got it. So what I heard was really short sales cycles in healthcare for the vendors.
That would be overly optimistic.
Yeah, I heard everything is going to be great. Well, I certainly agree with Dr. Jayne about from an IT perspective. I think, we're going to continue to see at a more global scale, more mergers and acquisitions, right? So a lot of these hospitals and clinics that have been kind of damaged by this fun pandemic that we are still going through are ultimately going to come to the decision that they can't do it alone anymore. And so we're going to see a lot more, or continue to see, I guess, mergers and acquisitions. And the other thing I think we haven't come to terms yet with, in the United States at least, is the Great Resignation. And now it's happening at a global level I think everywhere actually, but certainly it's not just a healthcare thing, but doctors and nurses and technicians and pharmacists are at alarming numbers deciding that they are done and they are either retiring or looking for other things that they can do that are kind of adjacent to healthcare. And so that is a problem that's not going away. You have hospitals today that are spending millions of dollars on traveling nurses. And oftentimes those are nurses traveling from the suburbs. And so they're not going across the country. They're really nurses who were just working at that hospital right over there. And they quit, and now for significantly more money, not a little bit, significantly more money, they're called a traveler. And that is not supportable long term, some would argue. Others would argue, yeah, you should have been paying them this much all along. And they bring a lot of value And so I don't know where it's going, but I see that as a major tripping point that we've got to figure out what's going to happen in terms of staffing our hospitals and clinics.
So it's interesting you talk about that, the resignation, because that what that does is essentially loads more on the clinical staff, because now you're spreading across a lower number of resources. Yeah, you've got this sort of pull in, but there's essentially this limited pool. And the other thing that we've seen very clearly in my mind is this massive increase, or maybe it's just an exposure of this behavioral health. And it's across whole chunks of society. I mean, we see it in the kids, we see it in society in general, but I guess very personally, certainly for me, and I would imagine for you both, is amongst the clinical staff who have just been bearing this burden. And to me, it feels like it was the case before. Is there any hope on the horizon around that?
So I'll go ahead and jump in on that one. I think that there is hope for folks that are working for progressive organizations that see what the problem is and are willing to make investments to address that. And, it's not just some of the things that we've seen over the last 2 years. You can't just throw a pizza lunch at it or a challenge coin at it and hope for the best. You really have to look at what are the organizational steps that you're willing to take to make life better. So, don't call the therapy dogs, yeah, they're fun and they're cute and we all love them, but I think we need to see change, along the order of magnitude of truly controlling patient volumes. And actually one organization that I worked with very closely over the last year that's in urgent care, and they've just literally been getting clobbered throughout all of this. They finally had to come to a decision that they were just going to cap their volumes every single day. So they open up in the morning, they take a certain number of patients onto the books. And when that number is met, and it's usually met within 30 minutes of when those schedules open, they're done. They're not going to continue to, harass the staff into seeing just one more patient, because they know the staff's at the breaking point. And they've actually seen a dramatic change in their staff retention rates since they introduced those caps. And they realize that they're losing patients to competitors. They realize that they're losing potential revenue. But I think they learned from the experiences that they had early in the pandemic that, it doesn't matter if you see one more patient. If you lose a seasoned staffer, that's a significantly harder thing to overcome. Those patient volumes will come back. The staff will not. And I look at my former colleagues and I was a little bit part of the Great Resignation. So I guess I'm part of the problem. So I should be part of the solution. I left my urgent care role earlier in 2021. And part of it was just not sustainable. The mental toll, the physical toll, and what was going on as our practice went through a private equity acquisition was just not something that I was willing to continue to do. And my peers, almost exclusively went to environments that had better work-life balance, whether it was, an 8-hour shift in a community ER versus a 12-hour shift at our place. We had 3 people go to a med spa. And I think that's really telling when people would rather do something that, they don't necessarily perceive as what they were trained for. I mean, that's a far cry from emergency medicine, but now these 3 are running a med spa. So that's just, it's very interesting.
And as you think about the work-life balance, I mean, that pervades everywhere. I mean, if I was to sort of tease out the one thing, if you were to try and solve it, it is the work-life balance. One of the things that I've heard a number of times now is a move to a 4-day working week. And part of this feels immaterial in healthcare because it's a shift-based, but is there some scope to maybe reduce hours overall, given that we've got insufficient resources, given the traveling nurses that you talked about, Craig?
Yeah, well, I would say this is my personal opinion. I think it's more of a quality issue than a quantity issue, right? And so if you kind of everything that I say often comes back to teams-based care and everyone working at the top of their license. I think physicians are going to be much happier doing jobs that they think bring value and that only they can do. And so having physicians look through tons and tons of messages that many of which can be competently and actually sometimes often better handled by others, by nurses or medical assistants. and letting docs do the things that only docs can do and that docs are really good at doing. I don't think people mind working that 8-hour shift, or even a 12-hour shift. Again, assuming that they think that they're spending their time well, and then since we like to bash electronic health records and sometimes technology. I don't personally, but Nick, you do all the time, and it's really inappropriate. It has to stop. Spending time in the electronic health record, not clicking boxes that really don't bring any value, that you didn't need to go to medical school and do a residency to do. That's often what gets people to go to the medical spas. And I completely understand it. Some of it is the technology's fault. Absolutely. Some of it's the electronic health record. Much of it, in my estimation, is the rules and regulations and legal environment that we find ourselves in the United States. So I think it's a combination of all of these things. It's not just hours, but the quality of time and what people are doing in that time.
So thinking about the technology, and the three of us focused on innovation. What can the technology bring? We just had the CES show, which had a whole digital health component. Anything that stood out that you go, wow, that could really help solve or resolve some of those problems? I mean, I think specifically to your point, Craig, all of the what I call scut work, which we used to unload on the junior doctors, I think we still do. They spend 70% of their time in the basement, to my understanding. We don't seem any closer. That was the same before. We were just doing it on paper. Now we seem to be doing it more digitally.
Yeah, well, I'll jump in on CES. I have kind of a love-hate relationship with CES this year. So despite being able to attend last year as a credentialed media person, this year they did not allow me to attend, would not give me credentials. And it was funny, though, because they sent a survey asking me why I didn't go. So I made sure that I responded, I didn't go because you wouldn't let me. So fortunately, I have a good network of folks that fed me a lot of interesting things. And they know I was really interested in the consumer side last year. It's funny because it seems like there was much more focus on interesting things for consumers, things to make people's lives easier at home, a lot of smart home technologies. And I think that's interesting from the healthcare standpoint, because a lot of those things that we may not consider to be really a health investment could be a health investment. So, the smart home devices, it's not just about convenience. When you start to think about patients that are mobility impaired or have different needs as far as being able to control things in their home, even when you think about like a voice controlled faucet, that seems very Jetsons. It seems very, very space age and like, do we really need this? But if you're someone who's mobility impaired or someone who has a sensory issue and you can't perceive temperature and you need to be able to tell that faucet, I want that water at 110 degrees so that you have more freedom to stay at home and not rely on caregivers. I think we need to start looking at some of those unique consumer offerings and figure out how they can fit into the healthcare infrastructure. And make sure that we have the ability to make those products accessible to our patients. I think being able to keep people at home is really going to be a big thing. This was not part of my predictions for 2022, but just looking long term at the aging of the baby boomers in the US and looking at folks that want to stay happier and healthier at home. Certainly remote monitoring and virtual primary care and all of those things that we're already talking about make a big difference in that. But also enabling those people to be able to do what they need to do from a technology standpoint, like a walk-in bathtub, that seems like such an out there kind of thing. But when you really think about it, what a difference that could make to a patient and being the difference between care at home versus care in a facility. I think that stuff is really interesting. So I enjoyed watching the consumer side from CES, a little bitter about the healthcare IT side. So I can't say too much about that.
So for those of you just joining, I'm Dr. Nick, the Incrementalist. Today I'm talking to Craig Joseph, as I do each and every month. And this month we're joined by Dr. Jayne. She is the resident blogger at HisTalk and also an emergency room physician. We were just talking about the innovation and specifically speech. And, most folks will know that I'm a big passionate player in that space. I've, done a lot of things, always seen the value. It was always the great leveler. And, subject to many jokes across, years of time. for its inability. But for me, it's tipped over, in part because we've gotten better at the accuracy. And as you rightly point out, Jayne, those things seem like they're, that's just icing on the cake, but it's not. And I saw that with my mother when she couldn't open the stupid bottle that was designed for childproofing, that was completely impossible for her. Now, you're not going to solve that with voice, but we do have to think about access. Craig, you've looked at this, throughout your career. Are we seeing some innovation in that space that will really change the way that we deliver care and allow people to age in their home?
Well, I think to some extent it's a technology thing. I feel like I'm a broken record. I'm very boring. To a greater extent, it's payment, right? Boy, you couldn't get paid as a physician to give advice over the phone or over the computer. You had to do it in person. Otherwise, it was free. And so we've had the technology for a lot of these things. We've had the ability to create walk-in bathtubs for a long time. It's just that, well, who's going to pay for that? And the answer was no one, which is why it's not going to happen. Society didn't benefit, or didn't see the benefits of it. And I do think and hope that a lot of, that this technology, which has maybe not been amazing, but has been acceptable, will now get looked at with a different light. And just like you said, how much is it to prevent a hospitalization? And now we really have to think at a high level, right? It's really a national question, not at an individual patient level. But I think it's going to be. We've talked on this radio show for a while now about the fear that some of the telehealth regulations that have been eased, that have been allowing us to do this for the last couple of years, are going to be removed when the pandemic starts to improve. And as long, and I feel like it's a danger, but becoming increasingly unlikely, because people are going to reasonably say, hey, why do you want me to come to the office again, just so I can tell you the answers to the questions that you can tell me over the phone or over the computer? And so yeah, I'm hopeful that they're there. Certainly technology's improved. The voice recognition is better, not so much in the being able to understand what I'm saying, but the words at least, but being able to understand kind of comprehension of what am I trying to get across, and then being able to react to that. Clearly that's much better. So yeah, as long as we don't shoot ourselves in the foot, Dr. Nick, I think that we're going in the right direction.
Well, I'm just going to say that the technology doesn't understand you because you have this funny accent. If you spoke the Queen's English, there wouldn't be this problem. I'm just saying, that's been my experience.
I admit it. I'm not going to get in a fight with you about this.
So let's talk drugs. It's this burgeoning problem that continues to eat into the limited pool of resources available. It went from somewhere the 5% of total spend. It's now easily at 20%. It's increasing. We've seen recent entrants. I've got to call out Mark Cuban. He's got this whole sort of concept to try and deliver generic drugs. There's a whole thing around generics as it is. Is there some pathway that we can see for our patients? And is this even the right thing to be thinking about? Are we just using too much of these things? Where do we stand on treatments and affordable treatments?
Yeah, I think this is really an interesting topic, and kind of going back to my primary care roots. We have this whole culture in the United States about just wanting to throw medications at things. Doing the things to avoid medications are difficult. Getting out and walking every day, getting out and exercising to maintain your weight, or making good food choices is difficult for a variety of reasons. Sometimes it's human nature and choice. Sometimes it's related to the availability of grocery and other suppliers. We have areas in our country that are food deserts, where there's not a place that people can go buy fresh vegetables that's easy to get to. So I think we've got a human nature piece. We've got, kind of a supply chain piece, but then we've got this relentless advertising. And I am 100% against direct to consumer advertising. It's all over the internet, it's all over television. And so often we can do what we need to do with generic medications. And I think patients don't understand that sometimes. And to have that thoughtful conversation and explain to them what it means to be a generic med, we don't get paid for that. We're on this throughput treadmill trying to see all these patients. And that's really an education piece. And that's a public health piece. And we've seen how woefully we've underfunded public health around the world and particularly in the US. And I think COVID is a prime example of this as well. We look at, what is the true cost of a vaccine? So, okay, if I have to get 3 vaccines, even if you figure $20 a vaccine for COVID, which is roughly the contracted price, even if they charge, another $20, $30, $40 for administration, you're talking, a grand total of a couple $100 to potentially prevent a hospitalization, prevent a $15,000 to $20,000 hospitalization. And there's a lot of people that honestly believe that, oh, well, I don't need that vaccine. I'll just get Regeneron, or I'll just get, XYZ new pill that's being approved from Pfizer or Merck. And those are so much more expensive and they don't fix the root cause. So the reality is prevention is not sexy. Generic drugs are not sexy. And we need to figure out how to make them sexy if we're really going to turn the tide on this drug spending.
So, great point. I'm just going to correct you slightly and say that's not just an American problem. I can tell you with certainty that was the case, and it's partly because it was. I don't want to say getting the patient out, but it was giving a resolution that was immediate for an individual. That was part of handing the script. It was part of my environment. We clearly see challenges with this. How do we fix this? How do we go about this and turn the tide to allow for it? It feels like I'm going to ask you that question. You're only going to come back and say the same thing again, Craig. It's all about follow the money.
Oh, yes, Nick. It's all about follow the money. That one thing to think about. First of all, I think we can solve this problem by only allowing pediatricians. So just preventing all other doctors from seeing patients, only pediatricians, because we don't understand how this whole medication thing works. Because as I used to tell the parents of my patients, little Johnny generally gets better despite anything I do for him. And but it does change as we age, right? Like for young kids, it was just antibiotics for ear infections, right? And we do a lot less of that now than we did a couple of decades ago. Here's some of the problems again. And as you point out, I like to always highlight system problems. Physicians are now more than ever being evaluated based on how happy their patients are with them. And so if you walk into your PCP or your urgent care doctor's visit with the idea that because of direct-to-consumer advertising, you need X medication for your problem and nothing else is going to solve it, and you don't, God forbid, even get a medication, or let alone you don't get the medication that I wanted when I walked in, I am going to give you a bad review. And that has monetary implications ultimately, or promotion issues for them. And so, we get what we measure, we get what we ask for, and in that case, we're programming our physicians to give us these things that are. I don't think anyone's out there saying, "Well, I'll give you this medication even though it's going to hurt you." No, but I think that they're saying is, "Hey, I'm going to give you this medication more easily than I normally would have, and it may not help you. And what really is going to be helping you is exercising and eating well and doing those things." So, yeah, there are system problems, and if we don't at least talk about them, then we shouldn't wonder why these meds that people are overprescribing with little context or little proof are causing us such problems.
Yeah, great point. So Let me close. Unfortunately, we've run out of time, but let me close, as I do frequently, by pointing out that one of two countries that has direct-to-consumer advertising, the United States and New Zealand, still blows my mind. I still can't get my head around it. I can't ever see it changing. It seems like the push to keep that will continue, but in the meantime, we have to enable or empower our clinicians to combat that and combat the information void that exists. We've run out of time. It's been a true delight. Thank you for joining us, Jayne and Craig. As always, it's been a great pleasure. Thanks to both of you.
Thanks. Really enjoyed being here.
And again, I feel like I'm with royalty, so we should do this as frequently as possible.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at Dr. Nick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com, and tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.